Hello, welcome to sonography-radiology training channel. This series of videos is about basic radiology learning of chest imaging. This is the third video in this video series with title of Normal Chest X-ray PA Part 1. The outline of this presentation include introduction, viewing the PA film Part 1, teaching points, and a final quiz. At first, introduction. The chest X-ray posterior anterior film is the most frequently requested radiological examination. But always there is a very important question. What is the best system to look at an imaging study such as a chest X-ray? Some individuals systematically look at imaging studies such as chest radiographs from the outside of the image to the inside of the image. Others look at them from the inside out or from top to bottom. Some systems for reminding you to examine every part of an image have catchy acronyms and mnemonics. For example, ABCDE system. The fact is, it doesn't matter what system you use as long as you look at everything on the image. So use whatever system works for you, but be sure to look at everything. Looking at everything, by the way, includes looking at all of the views available in a given study, not just everything on a one view. And don't forget the lateral chest radiograph in a two-view study of the chest. The most important part of the system you use in interpreting images in a system in which you routinely increase your knowledge. If you do not know what you are looking for, you can stare at an image for hours or days, or in the case of the lateral chest radiograph, you can ignore an image entirely, and the result will be the same. You will not see the findings. There is an axiom in radiology. You only see what you look for, and you only look for what you know. So, if you don't know what to look for, you will never recognize the finding, no matter what system you use or how long you stare at an image. Viewing the PA film. Knowledge of the normal appearance of a chest radiograph is essential. Some prefer initially to view the film without studying the clinical information. Comparison of the current film with old films is important and often extremely helpful. The most important parts in a PA film we must evaluate include trachea, heart and mediastinum, diaphragms, pleural spaces, lungs, hidden areas, hilum, below diaphragms, soft tissues, and finally bones. We will discuss these items in video part 1 together. At first, trachea. The trachea should be examined for narrowing, displacement, and intraluminal lesions. Its midline in its upper part and then deviates slightly to the right around the aortic knuckle. Its caliper should be even with translucency of the tracheal air column, which decreasing caudally. Normal maximum coronal diameter is about 25 mm for males and 21 mm for females. The right tracheal margin, where the trachea is contact with the lung, can be traced from the clavicles down to the right main bronchus. This border is right paratracheal strip and is seen in about 60% of patients and normally measuring less than 5 mm. A left paratracheal line is not visualized because the left border of the trachea lies adjacent to the great vessels and not the lung. The tracheal bifurcation angle is about 60 to 75 degrees. We can see here the right side of the trachea and right main bronchus, left side and left main bronchus, and here is the tracheal bifurcation angle, famous as carina, which is about 60 to 75 degrees. Widening of the carina occurs in inspiration. pathological causes of widening includes an enlarged left atrium and enlarged cranial nodes. In this image, we can see elevated left main bronchus and widened carina because the patient has mitral valve disease and enlarged left atrium. Heart and mediastinum. The central dense shadow seen on a PHS film compromises the mediastinum, heart, spine, and sternum. With good centering, 2/3 of the cardiac shadow lies to the left of the midline and 1/3 to the right. Also, this is quite variable in normal subjects. In heart shadow, the right side related to right atrium and the left border is related to left ventricle. Also, we can see behind the heart the shadow of the descending aorta. This is the right border of the descending aorta and this is the left border. We can see at the up aortic knuckle and the left border of the descending aorta. The transverse cardiac diameter and cardiothoracic ratio should be assessed. This is the right border of the heart, this is the left border, and this is the transverse cardiac diameter. Here is the right border of the thorax, this is the left border, and this is the transverse thoracic diameter. The normal transverse cardiac diameter for females are less than 14.5 cm and for males less than 15.5 cm. The normal cardiothoracic ratio is less than 50%. All borders of the heart and mediastinum are clearly defined, except where the heart sits on the left hemidiaphragm. In babies and young children, the normal thymus is a triangular cell-shaped structure with well-defined borders projecting from one or both sides of the mediastinum. Both borders may be wavy in outline, famous as the wave sign of Malway, as a consequence of indentation by the costal cartilages. The thymus is absent in DiGeorge syndrome. A large thymus is more commonly seen in boys. Now, diaphragms. In most patients, the right hemidiaphragm is higher than the left. This is due to the heart depressing the left side and not to the liver pushing up the right hemidiaphragm. In dextrocardia with normal abdominal situs, the right hemidiaphragm is the lowest. Dextrocardia is a rare congenital condition in which the apex of the heart is located on the right side of the body rather than the more typical placement toward the left. If the dextrocardia associated with normal abdominal situs means the liver on left side and the stomach on the right side, the right hemidiaphragm is lower than the left. A difference greater than 3 cm in height between two hemidiaphragms is considered significant. Both domes have gentle curves which steepen toward the posterior angles. The upper borders are clearly seen except on left side where the heart is in contact with the diaphragm, and also in cardiophrenic angles when there are prominent fat pads. The cardiophrenic angles are between heart and diaphragms. Sometimes there is prominent fat pad here, as we can see in this chest X-ray, causing the upper borders of the hemidiaphragms are not clearly seen. Otherwise, loss of outline indicates that the adjacent tissue doesn't contain air, for example in consolidation or pleural disease like pleural effusion. Free intraperitoneal gas outlines the undersurface of the diaphragm and shows it to be normally 2 to 3 meters in thickness. Pleural spaces. The pleural spaces of the lung include the fissures and costophrenic angles. The main fissures of the lungs are right oblique fissure, left oblique fissure, and right horizontal fissure. These fissures separate the lobes of the lung but are usually incomplete, allowing collateral air drift to occur between adjacent lobes. The horizontal fissure is seen often incompletely on the PA film running from the hilum to the region of the sixth rib in the axillary line, and may be straight or have a slight downward curve. All fissures are clearly seen on the lateral chest radiograph, which will be explained in future videos, of course with God willing. Accessory fissures. Several accessory fissures have been defined that have low prevalence and are rarely seen on chest X-ray and are more often seen on chest CT scan. These fissures include the azygous fissure, the superior accessory fissure, the inferior accessory fissure, and the left-sided horizontal fissure. The most common accessory fissure which we can see in the PA chest X-ray is azygous fissure. The azygous fissure is a coma-shaped with a triangular base peripherally and is nearly always right-sided. It forms in the apex of the lung and consists of paired folds of parietal and visceral pleura plus the azygous vein which has failed to migrate normally, and the part of the apex of the lung that is separated by it is called the azygous lobe. The left-sided horizontal fissure separates the lingula from the other left upper lobe segments. This is rare, but in one study was found in 8% of post-mortem specimens. Other pleural space is costophrenic angles. The normal costophrenic angles are acute and well-defined but become obliterated when diaphragms are flat. The lungs. By comparing the lungs, areas of abnormal translucency or uneven distribution of lung markings are more easily detected. We can compare the both lungs from apex to base in this manner. The size of the upper and lower zone vessels should be assessed. In the upright position, the blood flow to the bases is normally greater than the flow to the apices because the effect of the gravity. Therefore, the vessels at the base are normally larger in size than the vessels at the apex of the lung. Normally, blood vessels branch and taper gradually from the central part or the hilum to the peripheral or near the chest wall. The extent and location of any opacity is determined, and specific features such as calcification or cavitation should be noted. A general survey is made to look for further lesions and displacement of the normal landmarks. As we can see here, obvious mediastinal shift to the right side due to massive pneumothorax. Now, please pay attention to these teaching points. The most important part of the system you use in interpreting images is a system in which you routinely increase your knowledge. There is an axiom in radiology: you only see what you look for and you only look for what you know. Comparison of the current film with old films is important and often extremely helpful. By comparing the lungs, areas of abnormal translucency or uneven distribution of lung markings are more easily detected. Now, a final quiz. Please write the finding in this chest X-ray and its reasons in the comments. Now, I suggest 2 others of my videos that are close to this video in terms of matter. And thank you for your attention.